everyone, my name is Grace Yoon, and I'm also doing this DNP residency course with you guys. Throughout this semester, especially the past couple weeks, I've had a lot of trouble thinking about a potential DNP project I can do because I really want to be able to begin and finish a project at a place where I'll be working as an NP. But in the past couple weeks, I actually got a job offer as an NP at a different emergency room. So I was kind of going back and forth as to what kind of project I should do for these assignments. But I decided to do it for where I currently work as a registered nurse. I'm at Inova Fair Oaks Hospital emergency room, and it's a small 38-bed community hospital. The Fair Oaks, Virginia area has roughly about close to 34,000 people. It includes a variety of diverse ethnic backgrounds, but the most that we see are Caucasians, Asians, and Hispanic, and as well as African Americans and Middle Eastern people. And roughly the average age is about 34, but we see a lot of middle age, 50 to 60s, and elderly because there's a Sunrise nursing home literally right down the street from the emergency room. And we also see pediatric patients, so we see a wide range of patients. And in this area, the median household income is a little over 100,000, and the poverty rate is 6.9% roughly. So the most common health issues that we see in this emergency room is abdominal pain, chest pain, code stroke patients, shortness of breath, alcohol intoxication, or like syncope, like GI issues, and fever. And I actually asked my nurse manager to see if I can get some data on the number of patients that we've seen and with the conditions that are coming in. And from January to June of this year, we saw roughly about 2,900 abdominal pain patients, and about 1,600 chest pain, roughly 1,400 fevers, 1,000 shortness of breath, close to 300 altered mental status patients, 500 alcohol intoxication patients, and the list kind of goes on. So one of the clinical issues that I've experienced that can be a potential project at this emergency room is I started working there around September of last year, and ever since around Thanksgiving in November until now, we've had this issue of a surge in patient volume and an increase in patient acuity, and this in turn results in the overflow of the emergency room, and it adds a lot of stress and overwhelming workload to the nurses and technicians as well as the providers. A little background about the emergency room is because it is small with 38 beds, it's divided into two cores. It has a total of 7 zones, 6 of which have 4 rooms each and a hallway bed, and the 7th zone is a pediatric fast track zone with 6 rooms. 2 other rooms we don't really use we do use, but one is reserved as our high acuity or trauma crash bed, and that's mostly when we see our code patients that come from the field, that most of them do not make it, and then our ICU patients that need to be stabilized, or patients who need to be stabilized before going upstairs or transferring to Fairfax emergency room or Fairfax Hospital. Our fully staffed nursing team includes 12 nurses, so a nurse manager, our charge nurse, triage nurse, resource, float, and 7 zone nurses. And then our fully staffed clin tech team includes 7 clinical technicians, a triage tech, float tech, pediatric fast track tech, and then 2 techs in each core. And as for the providers, they're a fully staffed MD group, provider group is 3 MDs and a 1 mid-level, whether that be an NP or PA. Because the emergency room is only 38 beds, and the hospital is a small hospital, there's only 182 inpatient beds. If there's not enough beds on the inpatient side, then the ED begins to board patients down in the emergency room and where we provide inpatient care. This directly affects by decreasing the capacity to see more patients and more quickly and discharge in the emergency room. So it's kind of like a both-way street. When we have an overflow in the emergency room, but there's not enough beds upstairs, we start to board. We also have a results waiting area where there's 4 reclining chairs, but that area is barely used unless the rooms and all the halls are filled and there's more than 10-15 patients waiting in the ED lobby. However, when it is used, it's not used as a results waiting area, it's used more as a fast track area. When the surge patient volume occurs with the increase in acuity, the wait times for the patient and the length of stay also increases. Sometimes there's not enough rooms to put a high acuity patient that comes in who may need to be monitored. But if patient discharges, and a room opens up, we quickly put them in a different room. Or sometimes we place them in a hallway bed, and when a bed becomes available in a monitor room, then we kind of play musical chairs with the beds in the rooms. There are sometimes not enough resources such as the nurse and the techs to handle the volume, and even with nurse and tech holes also affect the increase in surge volumes. So like I said before, the length of stay increases. Diagnostic tests and medications become delayed as the patient-nurse ratio increases. With how this issue affects individual health outcomes, provider practice, system processes, and agency capital resources. In health outcomes, it's more increased waiting times, increased length of stays, delayed diagnosis due to delays in tests, and with the door to provider time increasing. Sometimes the patients are not even seen by the providing nurse until the patient's condition is in a state of decline, which doesn't happen too often at this emergency department, but it has happened in the past. Higher acuity patients are not seen quickly enough, or there's just not enough space to put everyone in a room that needs to be in a room. For provider practice, doctors and nurses and clinics become very overwhelmed, and just the culture or the atmosphere and the work environment becomes a little too stressful. That also then in turn affects the patients as well. As for system processes, the inpatient flow affects the ED flow, and the ED flow affects the inpatient flow. There is a delay in diagnostic testing with an overwhelming number of patients who need the necessary tests such as X-ray, CAT scan, and ultrasound. And when I was talking about the ED patient or ED and inpatient flow, when there are a lot of inpatient discharges or not many inpatient discharges, that affects our ED flow as well when we have to board patients down there, and we get a surge of patients coming in who need those rooms. As for the agency fiscal capital resources, finances start to increase when more resources are needed. There are also surge bonuses given for nurses, techs, and providers, or when extra staff members are needed, and when there are holes to be filled. Surge bonuses also occur for physicians when the length of stays for patients become more than 4 hours, and there is like an overflow in the ED. And also, when there are some patients who leave against medical advice or not even being seen by the provider at all, because they think the wait time is too long. So that also affects and increases finances as well. There becomes a decrease in patient safety. Recently, patient falls have been a huge issue with us, but it has been improving a lot by providers like Clintex or nurses walking patients to the bathroom if they're able to walk and staying with them in the bathroom. And also patient satisfaction decreases as well with staff satisfaction with the increase of workload. As for key stakeholders, there's a lot of people, because it is the emergency room in the hospital, there's a lot of people that become involved. So there is the CEO, CNO, the CMO, and VIMA, which is the provider group, the nurses, registration group, hospital administration, that's including registration, the finance department, hospitalists, the charge nurse from each unit, acute care clinical director, such as the emergency room clinical director. There's physical therapy, occupational therapy, speech therapy, case management that is part of it, and also diagnostic radiology. So for the benefits of so including and proposing this potential DMP project as to you utilize the results waiting area to really have it just be a results waiting area, so we can get patients in and out of the rooms, and necessary patients who need the rooms to be in there. It would benefit the emergency room to improve the workflow, decrease overflow, and decrease costs and resources in the long run. As for providers, improve staff satisfaction and workload, and better teamwork across the units. And with patients, there will be a decreased length of stay, increased patient satisfaction and safety, and then healthcare system-wide wise, there's a better follow-through with transitional care after patient discharge, and an improvement in patient teaching. So I guess I just briefly touched on it, but in order to kind of resolve or improve this patient overflow and surge volume, is to utilize the results waiting area. And I'll talk about that in a little bit. But for going on to the next question, it says briefly talk about the national initiatives. So with the Agency for Healthcare Research and Quality, they created this PDF guideline for hospitals that was stemmed from extensive research and findings and reports due to a lot of patient overflow and ED crowding across the nation. So I'm going to read a little bit that was in the guide. It says nearly half of EDs report operating at or above capacity, and 9 out of 10 hospitals report holding or quote-unquote boarding admitted patients in the ED while they await inpatient beds. Because of crowding, approximately 500,000 ambulances are diverted each year away from the closest hospital. Crowding has been the subject of countless news articles, lawsuits, and research studies. When the capacity is exceeded, there are heightened opportunities for error. And the Institute of Medicine's 6 dimensions of quality, safety, effectiveness, patient-centeredness, efficiency, timeliness, and equity may all be compromised when patients experience long waits to see a physician, patients are boarded in the ED, or ambulances are diverted. A more recent study was conducted at different AMC showed that a 1 hour reduction in ED boarding times would result in over $9,000 of additional revenue by by reducing ambulance diversion and the number of patients who left without being seen. So the purpose of this guide was to present a step-by-step instruction for planning and implementing patient flow improvement strategies. And this guide has real life examples on how hospitals have implemented the steps, what kind of challenges they've encountered, and what strategies they use to overcome those. So like I was talking about the results area or results waiting area, the purpose of it is an area where low acuity patients can be seen and wait to receive medications or test results or be discharged after a rapid initial assessment. So this would include your ear aches or sprained ankle or arm pain, back pains. Excuse me. And this helps accelerate the treatment and discharge times for low acuity patients, so we can see more patients and decrease the overflow in the lobby, and also help increase the necessary admissions for the higher acuity patients or transfer out. So the Cleveland Clinic Medina Hospital in Ohio actually adopted a split flow model. That helped reduce wait times in the ED, and this process helps the sickest patient to be seen quickly and to facilitate the care of less sick patients. So they use a mid-level to see these low acuity patients, and they also implemented using a results waiting area. And with that, after implementing the process in 2011, they saw a average of door to discharge time decrease to 1 hour and 58 minutes, close to like 2 hours, and with some patients just being in and out in 20 minutes. So from a personal level, what I've experienced in this emergency room, there is a burden when having to have 4 rooms and 1 hallway bed. That's 5 patients, and with different ESI levels, you can have a really sick patient, while you have 2 like less sick patients, and then like 1 ESI level 5 with a sprained ankle. I apologize for that. So with that, having to take care of 5 patients and running around with so many people waiting in the area, waiting in the waiting room, and patients are being impatient. Their wait times for the diagnostic tests become very, very long. Patients start to complain, and even with the order, like the protocol orders that we place with blood work and ordering diagnostic tests before the provider sees them, sometimes is delayed because the necessary diagnostic tests, which a lot of people need, like CT, ultrasound, or X-ray, it gets backed up, and in turn the final results can also take a long time as well. As for the provider's point of view, some of the MD providers, they were talking about how with the overwhelming and overcrowding ED, there should be an increase of surge bonuses that need to happen when there's extra hands that are needed. And also with the overwhelming ED, there's staff satisfaction that's also affected, and which in turn affects patient care and their satisfaction when they come to a busy emergency room. With question 7 on how this affects how this agency identifies issues and problems, there is actually a formal process where there is a daily morning staff huddle that includes all the stakeholders, including one of the C-suite members, all of the charge nurses and directors from each unit, hospitalist, acute care clinical director, PTOT, case management, radiology, they all have a meeting coming and discussing the status of their department, what their needs are, what areas are improving, and etc. So this, but and all this information and discussion stems from all the staff members that work in the unit, and the feedback they get from what works, what doesn't work, what needs to improve, um, and what they need. So let me see. At this stage, there is a few challenges and barriers to this issue. So it would be a lack of resources, the space, and the increase in funds in turn for the resources. There would need to be an extra nurse, such as a BSN registered nurse or even an LPN who can just give oral meds in the results waiting area, who can go over discharge instructions, or who can splint if necessary. And a provider would be necessary, so a use of a mid-level would be needed, and they would be designated to this fast track area. So an initial assessment would be done, and then necessary tests and medications, after they're ordered, the patient can be moved to the results waiting area. So that would be helpful in the emergency room. However, we don't have those resources right now, and we would need the funds to find those resources. But from an inpatient point of view, from an inpatient standpoint, one of the number one reasons why discharges are delayed and they don't occur in a timely manner is because a lot of patients are waiting for their rides. And it's mostly, I know I've worked in inpatient before, and we try to discharge patients before the afternoon or even in the morning to get the ball rolling. But a lot of the times family members are working, so they're waiting on their ride and they don't come until after they're finished work and there's traffic. So a lot of discharges get delayed, and this affects the number of inpatient rooms available, especially for those who need to be admitted from the ED. And when overflow occurs in the ED with no beds available, boarding begins, and this creates more of an overflow problem. And when we are a red status on our beds upstairs and we begin to board patients, that means, and even ICU, when ICU is filled or when we are filled, we take turns, or depending on who's filled, we become the crash bed. And when we become the crash bed and there's no ICU patients, then patients get transferred over, or we have to divert the ambulances to the next nearest hospital, which is about 30 minutes away within the Innova system. So in turn, this project may be a bigger project to a simple solution, but it's only because it doesn't only involve the emergency room. It involves the whole hospital, including the inpatient side and everyone who works within each department. I believe that this would be a great DMP project, and even if this isn't started or begins at Fair Oaks, this could potentially be a good project at the emergency room that I'll work in the future. Or and if it's not, this process of just getting to know who the stakeholders are, what needs to happen, what initiatives need to be researched, and it's been very helpful to kind of maybe take this into and work with a different project. So thank you for taking the time. I know my video is super long, but thank you for taking the time to listen, and I would really appreciate the feedback. So thank you.